Let us continue with our session on microbiology reporting interpretation. Let us understand how to interpret two examples of some case studies. When a microbiology report is released, we get to see various antibodies are sensitive. Now, how to see which antibiotics should we use? There are some rules or some guidelines that can be followed to select the right antibiotic. Rule number one states that always start with a beta-lactam antibiotic if possible, especially in severe infections, because they are the best data supporting their use and are in general excellent drugs, except in case of some atypical infection. Rule number two is that do not compare the MICs between drugs. The MICs may be different for the same sample for the same organism against different antibodies against different samples. Each antibody has a different serum concentration, tissue concentration, and pharmacokinetics. Each antibody has different pharmacodynamic parameters. Some are time dependent, some are constant dependent, some are AUC by MIC dependent antibodies. Rule number three says that if the antibody is reported sensitive, that is MIC is lesser, you can still use the drug, but except in cases such where drug does not get to the site of action, drug doesn't achieve its pharmacodynamic parameters, drug doesn't have inducible resistance, there are patient-specific factors that doesn't limit the use of drug, and drug costs. Rule number four is that microbiology always has more information than what is reported. So the microbiology lab can be taken help or guidance for interpreting the reports or getting some additional testings on the sample. Microbiology results have results more in hand before they are reported into the computer. Antibiotics may be suppressed in the microbiology report, so the microbiologist can perform additional testing as required. Now, which antibiotics should we choose in this report? Where ampicillin, daptomycin, penicillin, and vancomycin are sensitive, and it's a blood culture and Enterococcus faecalis. So let us apply this. Always start with beta-lactam antibiotic, ampicillin, because it's ampicillin sensitive. Now, don't compare MICs between so we will not compare the ampicillin with daptomycin and vancomycin. Because daptomycin will not be a better drug as compared to ampicillin because the MIC is lower. So even if you can use this drug, but remember some some exceptions such as cost effectiveness. So the current cost effectiveness ampicillin will be better than vancomycin and daptomycin. Also consider the rule number 4 that microbiology has more information. So microbiologists can also test for linezolid, which is the oral option. But still ampicillin will be preferred seeing the cost effectiveness, and ampicillin will be the drug of choice for this case. Similarly, later this is how microbiology reports are interpreted. Let us take another example. Which antibiotic will you choose for this case? Where urine culture yields Klebsiella oxytoca is ESBL producer. All organisms are resistant except C418, which is sensitive, and then levofloxacin is sensitive, meropenem is sensitive, nitrofurantoin is sensitive, and tigecycline is sensitive. Now, before proceeding how which antibiotic to select, let us understand some more information. Whether it is a cystitis or pyelonephritis. If it's cystitis, then it's a male or female. If female, then how old? Let's assume that this is a cystitis in a young adult female with no comorbid condition. Then another question: Do you want IV or oral administration? Now let us apply the rules. Always start with beta antibiotic. So we will consider C418 and meropenem. But these are the IV drugs. So though and also it is an ESBL producer. So C418 should not be used for ESBL producer organism. Also meropenem is appropriate, but it is IV. C418 is IV, and so we will move to the next group of antibiotics such as quinolone. But again, ciprofloxacin is related to resistant. Levofloxacin will not be used because of the cross resistance issue. So another option is tigecycline, but tigecycline has a poor urine penetration, so it won't be used. Again, it is IV also, so we are left with only one antibiotic, is nitrofurantoin. Again, microbiology can test more drugs, so you can test for fosfomycin also, but fosfomycin being expensive, we will stick to nitrofurantoin. So the antibiotic for this case will be nitrofurantoin. This is how the pharmacokinetic, the pharmacodynamics is because the cost effectiveness and other such resistant factors like ESBL. Such factors need to be considered while selecting the right antibiotic. Let us take another case. A 67-year-old smoker presents with fever and cough for 1 week. On examination, there was a temperature, the decreased air entry. Which test will you send? The test will be CBC, CRP, kidney function tests, urine dipstick, and chest X-ray. The complete blood count will help us to get more information about the likelihood of infection. WBC with neutrophilia indicates bacterial cause. Urine electrolytes will help us to understand the renal function. CRP will help us to understand whether there is a bacterial infection. Urine dipstick will help us to understand whether there is an UTI because it has 97 negative predictive value for UTI. Chest X-ray was done as a part of the thoracic category. So that was the reason why this list of tests. Now, what does this test revealed in their investigations? Blood revealed that there was a high WBC, high CRP, high urine electrolytes, high creatinine. The urine indicated that the nitrites were positive, leukocytes were positive. Chest X-ray showed consultation. What's the diagnosis? The answer is community acquired pneumonia. Why so? WBC and CRP indicated bacterial infection. Though urine was considered with diagnosis of ATI, but dual infection is very rare. Also, the positive predictive value of dipstick is very poor and it does not diagnose UTI. Chest X-ray has showed consultation, showed a diagnosis of community acquired pneumonia. So, based on chest X-ray appearance, the patient is examined for. Now, what will not be the sign of pneumonia? Whether it's crackers, dullness, and rosiness, or chest expansion. The answer is crackers. Crackers are actually signs of heart failure or fibrosis rather than consultation. The clinical findings are considered consultation. Hence, there will be decreased chest movement or decreased resonance or dullness, but crackers won't be present. Now, the further investigation ordered were sputum culture, blood cultures, and urine for Legionella antigen. Now, what will be the sputum appearance in case of community acquired pneumonia? It will be purulent. Appearance of sputum can help in distinguishing infection from contamination. Salivary means there is a chance of contamination. Mucoid means it is an upper respiratory tract specimen. Purulent indicates infection, inflammation, and constitutes diagnosis of. What happened to the patient? The patient deteriorated with saturation decrease, the temperature increased, heart rate increased, BP blood pressure increased, respiratory rate increased. Patient started having rigor. Now, what antibiotics should the patient be started on? The answer is coamiciclovir and clarithromycin. Most hospitals use a combination of beta-lactam antibiotic and a macrolide antibiotic for severe community acquired pneumonia. Peptide is unnecessarily a broad spectrum. Gentamicin doesn't penetrate to chest very well, and it is not active against non-culturable bacteria. But clindamycin is often considered a macrolide. It is usually a lincomycin and doesn't have any action against non-culturable bacteria. Teicoplanin and levofloxacin is reserved for severe community acquired pneumonia. So our drug of choice will be coamiciclovir and clarithromycin. Start with IV coamiciclovir and clarithromycin as curve 65 score was 4. Curve 65 score refers to confusion, urea levels, respiratory rate, and blood pressure and age. Now, what is not a cause of community acquired pneumonia from these organisms? The answer is Pseudomonas. Pseudomonas is actually a cause of healthcare associated pneumonia. It is a cause of community acquired pneumonia. Other causes are Staph aureus, Streptococcus, Haemophilus, Mycoplasma, Chlamydia, Legionella, and other viral causes. Next day, the WBC still is rising, CRP is rising, urea electrolytes and urea creatinine all are rising. Microscopy in urine showed a high WBC. Culture there was no growth. Blood culture was held at a gram-positive cocci. Now, manage the patient. Will it change it or stop it or persist? The answer is will persist. Why? Because there is no reason that the patient has anything other than community acquired pneumonia. The patient requires some time to respond to the treatment. Dropping the macrolide would be a mistake, as this means that non-typical. So results were followed up. Urine was negative. Blood was revealed coagulus negative staphylococcus. Sputum revealed staphylococcus pneumonia. Urine was positive for Legionella antigen. What is the diagnosis? Diagnosis is Legionella pneumophila pneumonia. Why so? Because the urine was and which has sensitivity and specificity of 95%. Hence, the diagnosis of Legionella pneumophila pneumonia. Streptococcus pneumonia in sputum can occur in absence of pneumonia, as it is part of the respiratory flora. And cons in a blood sample indicates contamination. So, what was the treatment? Treatment is oral levofloxacin for 3 weeks. Levofloxacin is superior to clarithromycin for treatment of regional hemophilia. Levofloxacin is a good bioavailability, and so if the patient is showing improvement, it is rarely necessary to give by IV route. Oral will be the preferred. So oral levofloxacin was given to the patient for 3 weeks of therapy. The patient made a full recovery. So this is how the patient's conditions, the investigations needs to be interpreted for the selection of the right antibiotic in patient care. What is antibiogram? Antibiogram is the overall pattern of the sensitive pattern of a particular healthcare setting, so against different microorganisms, against different group of antibiotics. It is generated by laboratory using the patient culture and sensitivity reports. It is generated at least annually, and it should be separate for OPD and IPD. It should be generally separated for high risk areas. The antibiogram helps in defining the antibiotic policy. It helps in guiding the clinicians and pharmacists in selecting the best antimicrobial. It is a useful tool for detecting and monitoring the trends in antimicrobial. This is what a sensitive antibiogram looks like. We get different percentage of sensitivity. The cut of sensitivity for selection to the empirical antibiotic is usually around 85%. In any case, the results of sensitivity testing need to be interpreted with some background knowledge of the organism, the pharmacodynamics, and antibiotics resistance mechanisms, and the patient history. Notice the antimicrobials if they are not necessary. Always take into account the natural resistance also, and check for any unusual results of the antibiotic against organisms. The patient history is very important to underline this is the previous treatment. The drug choices need to take into account the drug properties also like pharmacokinetics and pharmacodynamics. Whenever possible, use the narrow spectrum antibiotic or antibiotic for serious cases. Rapid detection of a resistance mechanism within few hours is possible with genotypic test. However, false positives are usual because of contamination, and they also can live organisms. We have biomarkers like CRP and procalcitonin. They are the most evaluated biomarkers. They are good but imperfect diagnostic performance is an issue. We have C-reactive protein, which is a slow induction, low specificity, however, and there is no correlation with the severity of infection. CRP is used to monitor the courses of infection. Procalcitonin has a rapid induction. Its levels roughly correlate with the severity of infection, and cost is also a major determinant. The procalcitonin level of less than 0.1 means bacterial infection is unlikely, while the level of more than 0.5 means bacterial infection is very likely. So, when bacterial infection are very unlikely, they consider repeating the testing after 6 to 24 based on clinical condition. If the levels are high, consider stop the antibiotic therapy. Then we have similar bifungal biomarkers like beta-glucan and galtomanan. Galtomanan helps to detect the aspergillus infections, while beta is usually indicator of candida infections. Beta-glucan is a polysaccharide component of many fungi. Galtomanan is a polysaccharide cell wall component of aspergillus cell wall. So routine is for aspergillus, while beta-glucan is routine is for candida and aspergillus. So there have been sensitivity and specificity issues with both the test. Serum beta-glucan sensitivity is about 50 to 95% and specificity 75 to 96%, while it is 80% for invasive aspergillus for galtomanan. So the take-home message is that there can be infection without culture positivity. So culture positivity without infection can occur. So never treat a lab report. Treat only the objective defined infection. Never treat a normal flora, unsterile surfaces, or colonization of sterile surfaces. The message is that choose the correct test, correct interpretation. Rapid communication is essential. Appropriate adjustment of the antibiotic based on diagnostics is the key to optimize the antimicrobial prescribing. POCT, that is point of care test, rapid assay, enable the early identification and initiation of antibiotic therapy. But a negative POCT doesn't mean absence of a disease, and positive test may be false positive too. Biomarkers are as good as a rule out test and has a high negative predictive value, but cannot guide the initiation of antibiotic. So that was all from my session. Thank you.